Hey there, everyone. Welcome back to Optimized Health. You're hearing my voice, Laura Chastain, today. Unfortunately, I don't have a co-host with me today, so this is new for me. I'll try to fill in the gaps along the way and make this as interesting and humorous as my co-hosts do on a weekly basis. Today, I'm super excited to have with us Madison Thomason. She is a licensed genetic counselor, along with Toria Williams. Toria is a patient in this realm. And so a first for us to actually have a patient in to talk about real world experiences, real life feelings and emotions and decisions that go along with genetic counseling and with genetic testing. So welcome, ladies. Thank you for joining us.
Thank you.
Thank you so much for having us.
Absolutely. We are thrilled that you're here today. And just to bring our listeners some more information about what is a genetic counselor, why would you want to see one? What are some red flags around that? And then to also weave in Toria's story that will help us understand some of the emotions, decisions, and specific circumstances that would require us to then seek genetic counseling. So, Madison, I'll start with you. Can you give us just a little bit about your background? Tell us about your story, kind of how you came to genetic counseling and what you do on a daily basis now.
Sure. It starts back my junior year in high school. I just loved the genetics chapter of biology.
Those Punnett squares?
The Punnett squares.
Yes, me too. Big B, little b.
Sugar cookies
yes.
with the Twizzler chromosomes in them. So that just really piqued my interest for genetics. At that point, Google searches were minimal, but I do believe I got on the dial-up internet and looked up careers in genetics. What can I do with this?
Wow.
And stumbled upon genetic counseling, which is a relatively new field. So grateful that I did because it ended up being a perfect blend of science and people. I knew I wanted to work with people. I didn't want to be in a lab working, with test tubes, that I wanted to have that patient interaction, but I loved the science and the medicine of genetics. So this has just been a great career for me. I have been practicing for 14 years now.
Wow.
Always in the oncology space for all 14 years, but the first 5 years I also was doing some pediatric general genetics as well at our local children's hospital here. I am currently specializing in women's oncology now, so always have done general oncology and even a more specific niche now with GYN oncology.
Wow. And in the last 14 years since you've been in practice, just from my perspective, I have seen this area explode.
Yes.
We've seen just an evolution of how genetic testing has gone from just a few things to so many genes that now we can look at. Are you seeing that too? Do you feel like it's like drinking out of a fire hydrant sometimes, where you're just learning having to learn so quickly and stay abreast of the new testing and what's available and explaining that to patients? Do you feel that way as well?
Oh, absolutely. I tell people genetics changes about every 5 minutes.
Yes.
So I'm constantly having to check for updates to the guidelines and new research that's coming out. Absolutely. But that's what makes it exciting.
It does. It does. And so I'm going to bridge over to Toria. And Toria, you are coming to us from more of a patient perspective. Can tell me a little bit about how you and Madison got connected and just a little background to your story as well.
Sure. So mine all started, my aunt, actually, who lives in Spartanburg, South Carolina, was diagnosed with breast cancer at a later age, at 71 years old.
Okay.
And her physician there suggested BRCA testing, and that her family, her sisters, her brother, everyone, her children get tested. And we had never heard of any of this. And so my mother got tested and was positive. And so subsequently, after kind of ignoring it for a little bit, I decided to get tested as well. So 2019, I believe, is when I was tested positive.
Okay.
Subsequently decided to get an elective hysterectomy. And this is when it gets good.
Big decisions. Those are big real-world decisions.
So after the hysterectomy, they found cancer in my fallopian tube.
Wow.
With the pathology report. So just having to go through that.
Navigate all that. Wow. I know a lot goes into that decision. So when you were kind of in that process, talk through some of those emotions. Like, what made you what tipped it over the edge for you where you said, I'm actually going to get tested? Because I know a lot of patients find themselves caught in that space where they have a family history. I know we're going to get into that even more about how to make that decision. But when they have a family history, maybe somebody was positive, maybe negative, you know, but they're trying to make that decision. Talk through some of those emotions with
I think
us.
it's just to have that extra layer of support, and like, if you're negative, then that's great. But if you're positive, the surveillance that comes with it, I just always thought, well, okay, I'll just be extra careful if I am positive. And I also have 2 children, so then that you take that into account as well. But I mean, honestly, our family, like, we have a great deal of BRCA positives. So I've done the surveillance for a while now, 5 years, I guess. So yeah.
Okay, awesome. So did you ever have or find yourself in a place where you were like, I'm really unsure. Should I take this or make this decision? Were you always just confident that that's what you should do?
I've been in the medical field, so
that
I think
helps a
some
little
people
bit.
probably do have a level of anxiety about it, but I just it was my intention just to face it head on.
That's great. That's great. I know.
It's nothing to be scared of. That's the thing, is people need to realize that, you're doing a service for your family to get tested and see if you are positive. Then you take those proactive steps to keep your BRCA doesn't just handle like reproductive. It's dermatology, your eyesight, and what am I missing?
GI,
pancreatic cancer as well. So you have to get all of those screened on a regular basis.
Yeah, and it gives you just more information probably then to take those proactive steps.
Yes.
To protect yourself.
Yes.
And to catch something early, perhaps.
Well, and that's exactly what my story is. That through the elective hysterectomy, that is when the Dr. DePasquale found the cancer in my fallopian tube, which was minimal. I mean, it was stage 1A. I think it was I can't remember the size of it. It was very small, like 0.8 millimeters. But still, if that had been undetected for a year from now, I would have ended up with ovarian cancer.
Wow.
Which is extremely hard to detect.
Sure, yeah.
So through the BRCA testing and then the hysterectomy and then that being found, I'm so lucky. I just had to do 3 chemotherapy treatments.
Oh, wow.
And just be monitored,
of course,
for the rest of my life, basically.
Yes. And so you met Madison through that process. Talk a little bit about how that relationship formed, and then how did you guide her, Madison, to make those decisions? Kind of stepwise, go through that process.
Yeah. Well, like Toria said, it was a process for her to come to the place where she was ready to have testing. I mean, I tell everyone, you have a right to know and a right not to know. And you really have to be at a place where you're ready to take that next step and have the testing, understanding all of the implications that come with that. It's for you. It's also for your family and has implications for the future generations. So it's part of my job is to walk through those things with people, help them anticipate some of the implications that come downstream. Some things that people don't even think of. We won't get into all the nitty-gritty details, but even insurability. How could this affect my ability to get certain insurance policies if I have this genetic predisposition on my medical record? So just helping think through some of those things with patients so that they have a full confidence and peace that they're ready to move forward with the testing. And so really it was Toria, we had talked about it before when we initially met. Yeah, she said, oh yeah, I know I need to get tested. And then just kind of went about on with her life for a little bit. And then once she was finally ready, she reached back out to me. And then I felt confident knowing, okay, she's making this decision for herself. No one else is making it for her. And after we had a good chat and conversation, her understanding what all goes into this, which wasn't brand new because other family members had already walked that road before her.
Right.
And that helps sometimes because then you have that person that can provide support.
Right. I mean, I have several cousins who have, that they've turned out to be BRCA positive. Some are negative. But even so, we have that connection in our family that we talk about it. We talk about the surveillance. We talk about, proactively doing things like a hysterectomy or potentially, the mastectomy that can happen as well. So, and several of my cousins have elected for that. So that's just something that it's a continual conversation, and like I said, it's been 5 years, and I've done you do a mammogram, and then 6 months later do an MRI, and then a mammogram and an MRI. And it gets to be a bit exhausting, to be honest with you. I know that sounds, and I've told Madison this, I hesitate to sound like, oh, woe is me, I have to do that. I'm very lucky that I can be proactively having the surveillance. But there comes with that a bit of fatigue. And so the timing of it is just like, okay, well, I may consider, an elective mastectomy to reduce the reoccurrence of, or not reoccurrence, but the occurrence of breast cancer, that possibility, because it is quite a bit higher. What is the percentage for a BRCA patient? It's about 80%.
For breast cancer, it's 60 to 70% chance, lifetime risk by the age of 70 or 80 for a breast cancer diagnosis. So it's significantly higher than average.
Right.
So which is where risk reducing steps like a mastectomy is on the table. It's a reasonable option, but like Toria was saying, it's a personal choice.
Yes.
So some people with a BRCA mutation may elect to do that, and some people may elect to just do the surveillance, which is the every 6 months alternating mammograms and breast MRIs.
Right.
Gotcha. So outside of a family history, or inside that as well, what are some of the red flags that we, as just a general population and for our listeners, would want to be aware of, that would want us to pursue hereditary cancer testing?
Yeah. Knowing your family history is key. And Toria's family has been so good about communicating with each other and helping each other know their own medical history, so that then their family members can then take that to their providers and talk more about this. But, things to be aware of in your family history would be if you just start to see through multiple generations on one side of the family, the same or related types of cancers, and a genetic counselor can help you determine, are these related or not?
Right. That was my next question. Yes, exactly.
Or just the same kind of cancers,
Right.
Multiple breast cancers, or like with BRCA, we see breast and ovarian running together, along with some others, like Toria was saying, pancreas, melanoma, prostate also being part of that as well. So when you start to see those cancers kind of in a pattern in the family, it may not be direct,
Right.
Passing down through the family, but kind of a clustering of cancers through multiple generations. When we start to see at least some of those people getting cancer at a younger than average age. So generally the cutoff we use is around age 50. If you're 50 or younger, getting something like a breast cancer or a colon cancer, that would be a red flag. Doesn't necessarily mean it is hereditary. Only about 5 to 10% of cancer is hereditary. So most of the time it's not due to an inherited genetic predisposition. But in those families like Toria's, where it is, it's very important for those family members to know that. But yeah, young cancers would be a red flag. Rare cancers, things like male breast cancer, you don't hear about that very often, but
No,
it
you
can
don't.
happen. So those rare types of cancers would also be a clue to prompt someone, maybe I need to talk to a genetic counselor about this and see about pursuing genetic testing there. Rarely, we also include Ashkenazi Jewish ancestry in kind of that list of red flags. There can be, with certain BRCA mutations, they can be more common in people who are of Ashkenazi Jewish ancestry. So that's why you'll
Yeah.
hear about it a lot. If you Google this, it usually pops up in the list, and it kind of catches you off guard. How does that? What does that have to do with anything else on this
Right,
list? But
right.
that's where that comes from. There. Also, too, we're talking about breast, ovarian, but there are other genetic predispositions to, say, for example, colon cancer. So it's not just kind of these female-related cancers that we're talking about, and there's more than just the BRCA genes, the BRCA1 and BRCA2 genes. So even if you have a family history of colon cancer or colon polyps, lots of colon polyps, precancerous type, more than 10, over the lifetime. Those get us thinking about some different hereditary predispositions to cancer beyond just BRCA 1 and 2.
No, that's really good because, for the purpose of our talk today, we're really focusing more on women's health, but a lot of these can show up in a male as well. And so even with BRCA,
Yes.
that can come through that
Yes,
male line as
it
well. And I
can.
think that's so important to remember when we're talking to females that we ask for that paternal side as well and get that information. What about, I get this a lot. Someone has been adopted. How do you guide someone that, doesn't really know their family history? do you automatically say, well, then we should seek genetic counseling, or kind of what are their options?
Yeah, I would say definitely meet with a genetic counselor. I always tell people meeting with a genetic counselor is not a commitment to genetic testing. It's just having a conversation, just to learn, to be able to get educated about the options for genetic testing, what it can tell us and what it can't tell us. A lot of people think genetic testing is a crystal ball that's going to predict the rest of their life before them. And it's absolutely not that. It's probability, it's chances, you have an increased chance compared to average. But certainly someone can have a genetic predisposition to a certain disease like cancer and never actually get that disease. So talking with a genetic counselor when you don't know your family history can just help you know what those options are and have a realistic perspective of what kind of information you're going to get back from those results. And then, we can facilitate that if that's something they choose to move forward with. Just knowing there are limitations in the interpretation of those results. From my perspective as a genetic counselor, it's hard, particularly in the context of a negative result. Did we miss something? Is there something we didn't know about that we didn't test for? So that's where it gets a little more gray, is in the interpretation of those results when we don't have the context of family history to go off of. And then, insurance companies may not pay for it if there's not, family history criteria that we can check off there. But we do have very reasonable self-pay options for people now too that are much more affordable than they used to be. So cost doesn't necessarily have to be a barrier, even if someone doesn't meet criteria.
That's good to know. I've seen that happen too, just in the world of women's health. The BRCA testing used to be extremely expensive and hard to justify, but now there are a lot of other options. So how does one determine, and I definitely see the value of seeing a genetic counselor and getting their input and getting the right test chosen, but there are so many online options now. So how do you navigate that world of different options to, be tested for? Like, you could order a test for yourself, or, and it's not comprehensive necessarily. That's the thing. So will you speak to that just a little bit for me? Yeah,
there are so many genetic tests out there, what we call direct-to-consumer testing, which is like the over-the-counter genetic testing, that, you can get your own spit kit and sit in yourself and separate from any type of healthcare professional or provider ordering that for you. That would not be my recommendation. A lot of those tests are not medical grade tests. So I would always, go through a genetic counselor or some sort of genetic healthcare professional to guide those decisions and make sure you're getting the most appropriate, reputable, medical grade test out there, because there are so many options, and it can be overwhelming to choose and to navigate. There may be tests that are marketed to say, we do BRCA testing, as part of this ancestry testing or something broader, and oh, by the way, you can also get BRCA testing included. And they may only look at the 3 common Ashkenazi Jewish mutations. Well, if you're not of Ashkenazi Jewish ancestry, you could have potentially missed your diagnosis.
And I could speak to that as well. Just, I know that we can order things online, and we do a lot of that, or just people think, oh, I don't have to go to a specialist, but I will say, like, Madison's support throughout this is going on 6 years now. So just our relationship and how I know that I can, reach out to her, text her, call her. And it's been a process. So having her support and her knowledge, I think it's
invaluable,
priceless.
Yeah, the wisdom that comes with the expertise.
So
for sure.
You get what you pay for.
Well, and Toria is also a great example, because I always tell patients, because genetics changes every 5 minutes, please recontact me every 1 or 2 years to see, has there been updated genetic testing, updated guidelines? Is there anything we need to change about your plan of care and your medical management based on new information? And I'll be honest, that rarely happens. I tell everyone it's written in their letter, but I rarely get regular calls from people. And Toria has been so faithful to recontact me and just see, okay, am I still on the right track? Is there anything else we need to be doing? So she's done an excellent job of that.
So proactiveness, definitely is going to be in your favor if you're wanting to catch those things early.
Right.
What about when you get a result back and it says, well, this is not, we don't know the significance of this? Do companies tend to then reach back out if they do determine a significance? Can you speak to that a little bit? Because
Absolutely.
I've seen those results quite a bit where we may have detected a variance in a gene, and correct me if I'm saying it wrong, but we don't really know the significance of it.
Yeah, there's a gray area to genetic testing for sure. And that's part of the pre-test genetic counseling process, is helping you understand this is not a black and white test. Just like we said, it's not a crystal ball. There is a category of uncertain results that we can get back, what we call a variant of uncertain significance. A variant just meaning a genetic change. If we know a genetic change in the alphabet code of your DNA is harmful and puts you at an increased risk for cancer, we call that a mutation. But sometimes they'll find genetic changes in the blood or in the saliva that we're testing that you're born with. It's there. It's not a question of, is this really there or not? It is a genetic change that's present in you that you were born with. You probably got it from one of your parents, but we don't know what it means. So the interpretation piece is where it's unclear. Does this really cause a higher chance for cancer, or is it just a benign, harmless change that just makes one person unique from another person? We can have those kind of changes, benign changes, harmless changes, even in our cancer genes. So yes, there is ongoing research in those areas. The laboratories that I use, and this goes back to the over-the-counter direct-to-consumer genetic testing, you're not going to get probably all of that kind of service and ongoing research. I would definitely recommend, again, going through a genetic counselor and getting medical grade testing, because the laboratories that we're selecting are constantly researching those variants, and they're constantly testing more people. So they're going to be gathering data over time. And if they're able to reclassify that later down the road, they get new information that gives them more confidence to say, yeah, we really do think this is harmless. 5 years ago, we weren't really sure. We were on the fence, and we just had to call it uncertain or inconclusive, if you want to think of it that way. But now we have enough confidence to say this is harmless. This is now considered normal. You don't have an increased risk based on this particular genetic change. Or more rarely, so 80 to 90% of the time, those uncertain changes, when they are reclassified by the laboratories, are downgraded to a normal result.
Oh, yeah.
About 10% of the time, they may be upgraded to where they say this is a harmful mutation. We need to take action. And the labs that I choose, so not every lab, but the ones that I choose, do recontact the ordering provider after a reclassification to let you know, okay, we've got new information, and then it's on the ordering provider to reach out to the patient and give them that information. Yeah.
Are we seeing across the board more awareness about genetic testing with all of the direct-to-consumer marketing? Do you feel like patients and providers are heightened in terms of sending patients, referring patients? Do you feel like we're seeing an uptick in that, or opposite?
I do think the awareness is increasing for sure, and genetics is filtering into more mainstream medicine, primary care offices and OBGYN offices, not just our kind of traditional niches of pediatric genetics, Down syndrome and muscular dystrophies, things that we know to be genetic. Cancer has been, around for a relatively longer period of time, but we're seeing it infiltrate into other areas of medicine. So people are more aware, but also I do believe there is a lot of misinformation out there. There's an awareness, but there may not be an accurate level of understanding about what is available.
Which is just more of a reason than to see a genetic counselor and get that so that then you can make the right decision on your testing and what kind of testing to do. So we've talked a lot about what genetic testing is. Let's talk about what it's not, and you mentioned it's not a crystal ball. It doesn't give you, you're not able to see into the future to determine. But let's talk about some other things, like it's not just certain tests, for instance.
Yeah. Well, you mentioned earlier that there are a lot of genes now, what we call these multi-gene panels, where we can simultaneously assess, hundreds to thousands. There's even whole genome, whole exome testing, where we can essentially look at all the genes that we have, which is around 20,000.
It's amazing, isn't it?
Yeah. But there's lots of limitations with that our ability to obtain the data has exceeded our ability to interpret what that means in a clinically useful way, something that would be actionable, for us. So that's where we kind of get a step ahead of ourselves, that we can get the information, but we don't always know how to interpret it.
What to do about it.
And that's where, where genetic counselors are very helpful for getting all the information. But there's more than just the BRCA genes out there. So genetic testing is not just BRCA. It used in the cancer space. It was kind of it. That's all you got.
Yeah, I remember that.
15 years ago.
Yes.
That's all that was available. But now we have these multi-gene panels where there's so many other genes we can look at related to cancer, and not just breast cancer or ovarian, like the women's health genes. Could be colon cancer, melanoma. There are some rare kidney cancer predispositions, things like that. So we have the ability to go very broad with it, but in the context of all the amount of information you can get back, having a genetic counselor on board to help you discern what does this mean for me personally in the context of my family history. Right. Because you can have two people, even within the same family, that have the same genetic mutation and very different medical histories, and maybe even different paths of what they choose to do medically to be proactive or to, follow early detection pathways versus risk reduction, or what we used to call preventative pathways. It's really such personalized medicine.
Yeah, and that's wonderful. It's so unique to each person. We talk a lot about risk, and just, it's not one thing. It's not just your genetics. It's your environment, your lifestyle, the choices you make on a daily basis. And so we talk to our patients about being proactive with just their lifestyle choices in general, just to help them as much as they can choose a path that changes that trajectory for them and improves their health. And just optimizes what they have been given. So what happens then, like, Toria, we'll just bounce back to you for a minute. What happens then when you get that positive result? What goes through your mind? What, talk about some of those emotions around that in the decision-making process.
Right. Again, like I told you, I felt like I was very proactive, ready to get things done. I think that some people may have a different reaction, and that's perfectly normal. Right. Like, while I say I was ready to get it done, I also did wait for about a year and a half or two after I knew my mother was BRCA positive to get my own testing done. Sure. So I think there was a time right there where I just wasn't sure. Just thought, I'll handle it myself, because it's a 50-50 shot. Like, you're either positive or negative once your parents or once one of your parents is deemed positive. So I thought, I'll just make sure I get, my pap smear and my mammogram every year. But then I think with our first visit, I realized there was more to it with the surveillance. And when I realized I could get an elective hysterectomy, that was something that actually seemed, okay, well, let's take one of those pieces of the puzzle, off the table. Like, take care of that. I was 50 years old. I'd obviously had my beautiful children. Yes. So there weren't many more of those coming down the pike. So I was like, absolutely, and it's funny how life works. I actually was laid off from one of my jobs, like right before the surgery. And I thought, maybe I should just put this off. Yeah. Let's wait. Yeah. Get another job. And something in my head just kept going, no. Yeah. No, go get it done. Go get it done. And then subsequently, the cancer was found in my fallopian tube. Yeah. So I'm so grateful for that.
Absolutely. It really saved a lot of
100%.
Things that could be.
And honestly, the timing of it as well, that happened in late 2019. My last chemotherapy treatment was like late January or early February of 2020. And then COVID hit. Wow. Literally that next month. Yeah. So timing of it all was just a real godsend.
Yeah. Yeah. We see the grace around that for sure.
1,000%. I will just say that it didn't, obviously that was the beginning of my journey when I felt like, I've had a hysterectomy, check that box. Right. I'm good to go, But as these 5 years have gone along, and like I said, with having the mammogram every 6 months and the MRI every 6 months of the breast, there gets to a point where I'm pretty close to saying that I think I may consider an elective mastectomy. It just, again, takes it off the table.
Sure.
So it's one of those things that it's always in the back of your mind, and we've talked about this, that when you have that awareness that you are BRCA positive, it's a blessing, but it's also like always,
a reminder
on
that
the back of your, just poking
a
you.
reminder that you're vulnerable,
Yes,
Yes,
and there's the certain vulnerability with it.
Yeah. And I think about that a lot just in our roles too, Madison, that, we're all human. We all have a vulnerability. Just because we're a provider doesn't exclude us from, or just because you're in the medical profession doesn't exclude you from those things that could happen. And so it's a good reminder that, there is, we're not in control of everything, but at the same time, we have a choice in some of our health decisions. And it is good to hear that, we did maybe save you, or this
it's one of those things that it's a blessing, and I'm so grateful for it. But in turn with that, I want to make sure that other people know about BRCA, because we talked about it years and years ago, that it's not very well. It's more well known now, but especially 6 years ago, people were like, "You're doing what?"
Right?
Yeah. Why would you do that? People just think, "Oh, well, I'll deal with breast cancer when I get breast cancer," when they could, take this step,
be
proactive.
Yeah. And so that brings a lot more decisions down the pike, where you're having to now make some decisions about your breast. Outside of breast and ovary, what does BRCA, what does that put us at risk for, Madison? Can you because there is a lot of information out there about BRCA. But I think we do think about breast and ovary. So what are some other implications of being BRCA positive?
We were talking earlier about this is not just for women, it's also for men. And in Toria's family, it does come from her maternal line, but that's not always the case. So that's a common misconception.
My grandfather had breast cancer. My mother's father.
Interesting.
So
wow.
So
that
so
rare
there's that common
cancer.
misconception that it just comes through the female lineage, but it can absolutely come from a paternal or male relative. There are risks for men associated with BRCA1 and BRCA2, and we're saying BRCA, BRCA, tomatoes.
Right.
It stands for breast cancer gene 1 and breast cancer gene 2. There's two of them. And people, if they have a BRCA gene mutation, either one or the other.
Okay.
Typically, it would be rare to have both. And so for men, we can see a higher risk for prostate cancer and a higher risk for male breast cancer, even though we talked about male breast cancer being very rare in the general population, but it is higher for men who have a BRCA mutation, specifically BRCA2 more so.
Okay.
We can see pancreatic cancer. Again, that's more so for BRCA2 versus BRCA1, and that would be in men and women. Melanoma. Typically, we think of that being of the skin, but Toria was talking about her having to see an eye doctor now because there's a rare melanoma that can happen in the eye. So ocular melanoma can also, it's very rare, and even with a family who has a BRCA mutation, it's still rare. But when we compare it to the average person who doesn't have a BRCA mutation, it is higher. So we do add on annual eye exams and in some cases, pancreatic cancer screening.
Okay. And so, we'll kind of start to wrap it up here. What would you tell a patient, Toria, that was kind of faced with this decision? Maybe they had a family history. They were a little bit unsure of what they needed to do. What would you tell them? What would be your advice to them?
I would tell them to go straight to Madison.
Well, that is definitely.
I know, it's not a commercial for Madison, but it's just the truth.
Yeah.
The genetic, get the genetic testing. Don't stick your head in the sand. It is something that is extremely helpful to know. I feel like being proactive is, the best way to have control of your own health. So, Madison goes right in line with that, with the genetic testing, and continue to keep in touch with her, as she said that, the two of us have done as well. Like I keep going back to, it's been, almost 6 years, but this is not the end of the journey for my BRCA journey.
Right.
So, I mean, my children will be tested eventually. Again, it's that 50-50 shot. My brothers have been tested. My cousins have been tested. So it's like you're not just helping yourself, but you're helping your entire family. So I think that would be the most important piece to this is get tested and make sure that your family members are getting tested if you do have that history, which, I mean, it was only my aunt that had the cancer, and later in life, it wasn't like our family was, full of cancer, but then it just cascaded down our family line. And I mean, I can speak for all of my cousins that the awareness of it has been very powerful, I would say,
wonderful.
In our family.
In a positive way.
In a very positive way.
Yeah.
Yes.
And so I'm going to throw a surprise question at you, Madison. We'll see what you, I'm just curious, what would you like to see the world of genetic testing become? What are your hopes for that? We've come a long way in the last 15 years. What would be like something that you would say, if we had this or if we had that piece, what would make it impactful for our generations to come?
Yeah. I mean, I think we're already on the right track with all of this research that's being done, and the laboratories that are doing the testing being on the front lines and being very engaged in ongoing research. We were talking about those variants of uncertain significance. They've already made huge headway with some new technologies that have just come out within the last 4-5 years, where we can reduce the number of uncertain variants. We can better interpret these genetic changes that they find. And so we're not getting as many of those inconclusive results as we were a couple of years ago. That's really helpful from a clinician standpoint to have more normal results and fewer inconclusives for that. So I do think we're on the right track there. And so I'm looking forward to seeing that continued, new technologies to come out with regards to that. And then there's some of these genes that we test for on these panels that are milder. The BRCA1 and BRCA2 genes are in the more high risk category. We were talking that 60 to 70% chance for breast cancer, 40 to 60% chance for ovarian cancer. Those are very high numbers. But some of these genes that we test for are milder. They may come with a 25% risk for breast cancer. And knowing, well, okay, what do we do with that? Or even some of these genes, we don't have a number to put on it. There's not a percentage chance. I say, well, this gene appears to be linked to a higher risk for colon cancer, but I don't know how high. I can't give you a number at this point. So better refining those risk numbers and understanding also how those genes work in the context of family history and environmental factors, like we talked about that personalized medicine. A better understanding of that, because it's not a one size fits all. And even for the same mutation in 2 different families, it can manifest itself very differently. So understanding those nuances better of when is this gene more activated, if you want to think of it that way, and when,
or how is it going to express in that person?
And how other genes might interact with it to be protective or or activating it.
Well, awesome. Well, thank you both for joining us today, and for you, Madison, and the work you're doing to improve patient lives and just bring awareness. We always say in our clinic that, education is empowerment. It helps us to make those decisions to give us confidence and peace for years to come. And so what you're doing is providing that education for our community. And for you, Toria, for sharing your story. It's very personal, I know. And for you to be vulnerable to us and to the community, thank you for that.
Absolutely.
If someone wanted to reach out to you, Madison, where can they find you, or how could they find you? Would it be just online if they look for your name, Madison Thomason?
Yeah, perhaps I should Google myself and see what comes up. Or maybe I don't want to do that. I don't know. I am part of the National Society of Genetic Counselors. That's our national professional society. So they can find me there.
Awesome. So if anyone is looking for a genetic counselor, do they need a referral to see you from a physician, or can they? Yes, a referral is needed.
Preferred mode.
Preferred mode is a referral. So look for Madison Thomason in that registry.
NSGC.org.
Awesome. GC.org. That's geneticcounselors.org, I'm assuming.
National Society of Genetic Counselors.
Awesome. Well, as always, it's great to be with our listeners and with you all, just bringing some empowerment for those next health decisions. And so I'm going to close us out now, and we'll see you next time.